Hello everyone. So now we'll be going ahead with the gastroenterology. So this is actually part 3 of medicine endgame. Okay, this is part 3 of medicine endgame. Part 1 we had covered topic number 1 to topic number 24, which was related to cardiovascular system, that is cardiology. In part 2 we went ahead from topic number 24 to topic 25 to topic number 54. That is total 30 topics for neurology. Okay, and this is part 3. If you haven't watched part 1 and part 2, please go back and watch these two parts. So now we have third part, that is GIT along with hepatology. Okay, GIT and hepatology, and we have around 2 to 3 parts in this. Okay, so all details regarding this are given in the YouTube description. Please go, if you want to purchase this PDF, purchase from the link given in the YouTube description. So going ahead with first important topic, that is Achalasia cardia. Okay, so what happens is, you know that GI tract is innervated with two plexus, myenteric plexus, which innervates muscles, and one more is Orbach's plexus. Okay, so Orbach plexus or myenteric plexus, this is the another name of myenteric plexus. Okay, so this neuron degeneration occurs as a result of which supplies GIT muscles, they fail to undergo relaxation at lower esophageal sphincter. So Achalasia cardia is nothing but failure of relaxation of lower esophageal sphincter, as a result of which there will be dysphagia for solids and then liquids. Okay, so what is the mechanism? Lower esophageal sphincter tone is increased and there is high resting pressure, and peristalsis is absent because in distal esophagus there is no movement that is happening, and in proximal esophagus there is increased tone. Okay. Next, in radiology, what you'll see this bird beak appearance, because there is narrowing here, there is no dilatation. Okay, that tone is actually increased, as a result of which there is no dilatation happening, and dysphagia occurs because of that. On manometry, you won't get lower esophageal sphincter relaxation. So this sphincter, lower esophageal sphincter, doesn't relax. Okay, so treatment is simple. Treatment is Heller myotomy, where actually we do surgical resection of this muscle surrounding the lower esophageal sphincter. Okay, that is, muscular sphincter is resected so that passage of food becomes easy. Now, what is the clinical complication? Complication is there is increased risk of squamous cell carcinoma, and temporary relief is obtained by nitrates and calcium channel blockers. That is because calcium channel blockers are involved in smooth muscle relaxation. So this will relax smooth muscles. Okay. Now, some extra things that you should know is, one is pneumatic dilatation, which is in some cases after medical treatment fails and if the patient doesn't want surgery, you will insert a balloon inside the esophagus and then you will dilate it. So this is known as pneumatic dilatation. It works in some cases. One disease important, which is also a question asked in microbiology: which organism or which disease is involved in Achalasia cardia? The answer is Chagas disease. Okay, that is trypanosomiasis. Okay, Chagas disease. Next, it is Achalasia cardia is more common in young adults. Okay, now you shouldn't confuse this. One of the most closest differential diagnosis is diffuse esophageal spasm. So this is a spasmodic condition, whereas Achalasia cardia is where lower esophageal sphincter tone is increased. Okay, so you have to differentiate these both. Next, you will expect only solid foods dysphagia, but no, if it is solid only dysphagia, it is actually carcinoma. Solid plus liquid both, then it is in the exams, then it is equal to Achalasia cardia. So things are simple. Orbach's plexus, that is myenteric plexus loss, leads to lower esophageal sphincter hypertonia, leads to stasis of food, and then below the segment there is dilatation. Okay, now all these things I have discussed. What is the gold standard for diagnosing? It is actually manometry. Yes, it is esophageal manometry, where you actually see the pressure in the sphincters. Okay, and it will reveal that there is no lower esophageal sphincter relaxation. Which is the most common cancer type that is associated? It is squamous cell carcinoma, and bird beak appearance with the inability to swallow liquids. That is known as that is the term, MCQ term, that we will be looking for Achalasia. Now, progressive solids only is carcinoma. This is one important differential diagnosis. I think I have explained everything related to this. We'll go to next to hepatitis. So in acute hepatitis, there is hepatocellular injury, means liver cells are getting inflamed, as a result of which ALT is nothing but SGPT, SGOT is AST. So this SGPT or ALT gets elevated more than AST, and in some cases alkaline phosphatase will also get elevated. But we are talking mainly about viral hepatitis. Okay, acute viral hepatitis. So which is the most common virus? Yes, most common is HAV virus. Okay, hepatitis A virus in children, and hepatitis E virus is most common in adults and in pregnancy. Next, ALT is more than AST, suggestive of hepatocellular pattern. Remember, if AST is more than ALT, that means it is related to alcohol. Okay, alcoholic liver disease. Next, prognosis is poor if SGPT increases, prothrombin time increases, that is PTINR. PTINR is basically liver's ability to produce clotting factors. If PTINR is deranged, means liver has gone lot of injury, as a result of which patient will go into liver failure. If there is encephalopathy, which means there are CNS features like confusion, altered sensoria, or there are seizures, okay, then we'll call it as hepatic encephalopathy, and then it will lead to fulminant hepatic failure. Okay. Next, most common other causes of acute hepatitis are drug induced. Okay, so drug induced acute hepatitis is very common, and in your question in exam there are two questions that are asked. One is paracetamol related acute hepatitis, and second is ATT induced hepatitis because of ATT drugs. Which drugs cause? All drugs, all 4 drugs which are given in ATT, that is H, R, Z, sorry, 3 drugs. These 3 drugs cause hepatotoxicity. Now, autoimmune causes are also there. We call it as autoimmune hepatitis, and in this we get 3 types. Okay, there are 3 types of autoimmune hepatitis. In that we get smooth muscle antigen will be increased. Okay, smooth muscle antigen will be increased, ANA will be increased, and there will be increased IgG, and this will be more common in females. Okay, next, hepatitis E virus has high mortality in pregnancy. Just remember this much. Next, how do you how is HIV, hepatitis A, transmitted? It is transmitted via fecal-oral route, and it is self-limiting disease. Within 2 to 3 weeks, the patient will be back to normal, even if you give treatment or without treatment. It is symptomatic management. Now, next thing is AST more than ALT is alcoholic, ALT more than AST is hepatitis. There shouldn't be any confusion regarding this. If you assume that conjugated bilirubin rises only in, if you assume that it rises only in obstructive jaundice, you are wrong, because it also rises in hepatocellular type of jaundice. Okay, that is hepatic jaundice. Next, supportive care is given. That is the mainstay of treatment for acute viral hepatitis. Okay, so all these things I have discussed. I think there is nothing left over here. Next, we'll go to appendicitis, which is surgery plus medicine mixed topic. So what happens here is there is fecolith. Okay, fecolith means some fecal material which is actually hardened. Okay, and this actually obstructs the appendix, the lumen within the appendix. Okay, as a result of which there is obstruction, distension, inflammation, ischemia occurs, and finally it leads to rupture, where you will get right lower quadrant pain, and then you will get tenderness. So first, this is very important is in the question. If you see, if there is periumbilical pain, initially started around the umbilicus where there is T10 innervation, later it migrated towards the right lower quadrant, that is McBurney's point, then you have to think of acute appendicitis. So tenderness is around McBurney's point. Where is McBurney's point? It is junction between lateral 1/3 and medial 2/3 from the umbilicus to the anterior superior iliac spine. Okay, next, fecolith obstruction is the most common cause. You will get anorexia along with fever. There are 3 signs associated with appendicitis which you should remember. One is Rosing sign, second is Psoas sign, and third is obturator sign. Just remember these things. If anyone asks you Rosing sign is seen where, Psoas sign and obturator sign, just remember it is regarding appendicitis. Treatment is surgical approach only. Now, next, in pregnancy, what will happen is pain will be shifted upwards. Okay, so in pregnancy also we can get appendicitis. So this is a OBG with the surgery mixture. Okay, next, carcinoid tumor also most common site is near the appendix only, and hence carcinoid syndrome or carcinoid tumor is there, then also it can actually cause similar symptoms. So this is a differential diagnosis. Your treatment is IV fluids along with antibiotics. Now, never give laxatives. Okay, never wait for surgery also, because appendix, if it ruptures, then it will be fatal. Then don't confuse this with mesenteric adenitis. So in some diseases, especially when mesenteric lymphadenopathy occurs, that is where lymph nodes of the mesentery they inflame, no? There also you can get pain in right lower quadrant. So to differentiate, we use some score for appendicitis, that is Mantrel scoring. Okay, Mantrel scoring. Remember this much. Okay. Next, imaging, you can use USG and you can also use CT. Initial investigation will be USG. If USG appendix is not visible, then we go for CT. Next, pain migration pathway I have told you, first from umbilicus, then radiating towards migrating towards the right lower quadrant. Rosing sign is positive, appendicectomy is done, and if there is right lower quadrant pain along with anorexia, fever, along with leukocytosis, that is leftward shift, okay, then we think of appendicitis. If it perforates, then surgery is urgent. So Rosing sign. So what is Rosing sign? Rosing sign means when you apply pressure in the left lower quadrant, there is pain in right lower quadrant. This is known as Rosing sign. Psoas sign means when you stretch the leg, on extension of the leg, there is pain. And third is obturator sign. When you rotate the leg, then there is pain associated with it. So all these are indirect signs of appendicitis. Okay. So this is Mantrel's, which is known as Alvarado score. Okay. So Alvarado score has Mantrel's. Just remember these things. Maybe these can be asked. Okay. Next, chronic pancreatitis. So initially in chronic pancreatitis there will be healthy pancreas only, there is no issue with that. Then there is some changes, either toxin induced or there will be some drug induced or there will be some food related things. Okay, so irreversible pancreatic fibrosis, especially this occurs with tapioca use. Okay, in Kerala, especially where staple diet, staple food is tapioca, that actually leads to pancreatic stones, which causes chronic pancreatic scarring. What are the symptoms? Simple. One is pain will be there. Where will be the pain of pancreatitis? It will be towards the epigastrium and it will be radiating to the back. That will be the common case scenario. Second is because of pancreas getting affected, these bile acids are not secreted, lipases are not secreted, as a result of which fat doesn't get digested and you will have steatorrhea. And third is diabetes. So whenever you get this important combination, that is fatty stools or oily stools along with diabetes, always remember there is only one organ that is involved, that is pancreas, because pancreas has this exocrine as well as endocrine function. So major cause of chronic pancreatitis is alcohol. Okay, so alcohol is the most common cause of chronic pancreatitis in elderly. Second, pain relief occurs when patient leans forward. This is a very, very, very important clue in your MCQ. These are called MCQ indicators, which means when patient leans forward, his pain will get decreased. Associated with other features, always think of pancreatitis in your exams. Next, third is other causes. Okay, that is complications is pseudocyst, diabetes mellitus and carcinoma of pancreas. Now pseudocyst, what is pseudocyst? Because of the chronic pancreatic inflammation, there will be fluid collection which is lined by epithelium which is not squamous epithelium, hence it is known as pseudoepithelium and hence we call this as pseudocyst. Okay, now because of exocrine damage, what will happen? Fat digestion doesn't happen, and that's why we have steatorrhea. What is the investigation of choice? It is CT. Okay, CECT, contrast remnant CT, where we'll see pancreatic calcifications also. Pancreatic calcifications are hallmark of chronic pancreatitis. So what is the therapy? Simple. Whatever pancreatic enzymes are not produced, you will replace that with pancreatic enzymes, and second you will give insulin. Okay, now so in India we say something known as tropical pancreatitis. Okay, tropical pancreatitis, that is associated with the tapioca usage on long term, especially in the state of Kerala. We see this type of chronic pancreatitis. Next, in children, pancreatitis occurs in chronic pancreatitis in case of cystic fibrosis. What is CFTR? Cystic fibrosis transregulator gene. Okay, so because of these mutations, pancreas is also involved in cystic fibrosis. Do you remember pediatrics? Yes, cystic fibrosis occurs because of this chloride channels are defective. Chloride channels on this epithelial cells are defective, as a result of which we'll get various other manifestations also in cystic fibrosis. Like for example, bronchiectasis is there. Okay, and then there will be abnormal sweat chloride test. Okay, we do transnasal potential difference. So all these things you should remember. Okay, along with that we'll have involvement of pancreas also. Now, don't expect amylase always to be normal in case of pancreatitis. Lipase is more specific for pancreatitis. Amylase may be normal also. On the other hand, even if there is no pancreatitis, still amylase can be higher. Okay. Next, calling it reversible. See, pancreatitis, chronic pancreatitis is not reversible because once the scarring occurs, it is permanent type of scarring. Okay. So acute pancreatitis can reverse, but chronic, actually when it calcifies, there is not much scope for reversibility. So I have discussed all this. Yes, one more important thing is there can be deficiency of fat soluble vitamins because of indigestion of fat. Okay, that is fat absorption doesn't take place. So calcification along with diabetes mellitus along with pain. Calcification means what? Pancreatic calcification. So that should tell you that it is chronic pancreatitis. And amylase normal, it can be normal. Okay, I think I have explained everything. Yes. So next, cirrhosis. So cirrhosis we had also discussed in pathology, and here we'll be going through it superficially. So what is cirrhosis? When there is whole fibrosis of the liver along with regenerating nodules. Okay, that is called as cirrhosis. So end stage fibrosis along with nodular regeneration. Now because of this, there is increased pressure in the portal venous system. We call it as portal hypertension, which ultimately leads to liver cell failure. Okay. Next, acute liver failure. Okay, next, what are the common causes? Alcohol, hepatitis B, hepatitis C. Remember, hepatitis A and hepatitis E both are what? Both are acute hepatitis. Hepatitis B and C are chronic hepatitis. And there is an important upcoming entity which is known as NASH, which means non-alcoholic steatohepatitis, which is now known as MASH. MASH means metabolic associated steatohepatitis, where because of insulin resistance, metabolic syndrome, because of long-standing diabetes, dyslipidemia, we have fatty liver. Okay, so this is nothing but fatty liver progressing to steatohepatitis. Okay. Now remember that AST will be more than ALT in case of what? In case of cirrhosis. Now why is that? Because ALT is produced by this liver cells. Now these liver cells will die in cirrhosis. As a result of which, in cirrhosis liver cell is not there, so ALT is not produced, hence AST levels will be higher. So that is the reason we'll get AST more than ALT. Similarly, GGT will increase in case of alcoholic liver disease, and bilirubin will also increase. Next, what is the triad of portal hypertension? Very good. This triad you should remember. One is splenomegaly, second is esophageal varices, which can lead to hematomesis, and third is ascites. So this is the triad of portal hypertension. Complication is hepatic encephalopathy. Next, synthetic failure. So liver function is assessed by two important parameters, lab parameters. One is albumin, which will decrease if liver cell is failing, and second is prothrombin time will increase because clotting factors will actually decrease. Now, hepatocellular carcinoma risk is highest not with alcohol, highest it is with hepatitis B, then comes hepatitis C, then comes alcohol. Okay, so alcohol is the least one among the three factors. So cirrhosis is reversible only if it is detected earlier. Second, spider nevi, which is seen in case of cirrhosis patient, is because of increased estrogen. Now don't ask me why estrogen is increased, because we don't have time for that. Next, don't expect focal necrosis in cirrhosis. Cirrhosis is not focal necrosis. And second, if hepatic encephalopathy is given in question, don't miss it. Next, there should be sodium restriction. Remember sodium restriction, otherwise there will be fluid overload, ascites will worsen. Okay. Next, diuretics are important, and third is beta blockers in case of esophageal varices, because this will cause planktonic vasoconstriction, as a result of which there will be decreased risk of hematomesis. Okay. Next, AST more than ALT pattern I have told you, complications I have told you. Drug lactulose. See what lactulose does is, now why lactulose is used in hepatic encephalopathy is because there are some toxins released which are not metabolized in the liver. Now this liver toxins in the gut, okay, toxins should go to the liver. Liver should detoxify them. If liver doesn't detoxify, it will remain in the blood. It will go to the brain and it will cause some damage. That is called hepatic encephalopathy. Now what lactulose will do? Lactulose will be in the gut. Okay, in gut it will enhance production of, it will enhance growth of these acids. Okay, it will stimulate production of some acids which will be useful for the gut bacteria. Okay, so gut bacteria will actually convert ammonia to ammonium, because everything what happens in hepatic failure is because of ammonium. Remember, liver is the site of detoxification of ammonia. Now if ammonia is excess, that will convert glutamate to glutamine, and this glutamate-glutamine combination will interfere with CNS, and that is the reason for hepatic encephalopathy. Now what if I tell you that ammonia in the gut can be converted into ammonium? Ammonium means NH4 plus, as a result of which it is not absorbed into the blood, so there is decreased risk of hepatic encephalopathy. That work is done by lactulose. So these two things I have already told you, and yes, we'll go on to the next topic. Yes, so next topic is colon cancer screening. So in colon cancer screening, this is a mix of surgery also as well as pathology part. So it should start, when should it start? Very important topic. It is at more than 45 years, and there should be prior history of family disease where there was colon cancer. Now, what is the progression of colon cancer? Initially there will be adenoma, colorectal adenomas, then it will lead to dysplasia, and finally it will lead to carcinoma. So we do colonoscopy every 10 years after 45 years. It is the gold standard. Okay, so colonoscopy. So which are the high risk age groups? High risk age groups are familial adenomatosis polyp and IBD, inflammatory bowel disease. These two conditions you will have to start colorectal screening at 20-25 years or 10 years before case has happened. Okay, so this is the protocol for screening. Now along with this, you will also do fecal immunochemical test annually, and you can stop once the age is 75 years or if the test is negative. Flexible sigmoidoscopy, where you won't scan the entire colon, it can be done every 5 years. Okay, so flexible sigmoidoscopy every 5 years, colonoscopy every 10 years, and annually fecal immunochemical test. But the most common practical consideration is colonoscopy only. Now, aspirin is shown to have a modest benefit in chemoprevention. So your question will be, which of the following drugs is shown to be protective in case of colorectal carcinoma? That is aspirin. Next, FAP has 100% risk, so you will have to do always prophylactic colectomy in case of familial adenomatosis polypi. Next, what are the fatal traps? One is believing that, so that is fecal occult blood test. Okay, fecal occult blood test, where we see for occult blood. Now this is not the substitute for colonoscopy. It is used as a screening test to detect if there is bleeding from intestines, but it is not the test of choice. Test of choice is always colonoscopy. Okay, early screening should be done in case of familial adenomatosis coli. So your question will be like juvenile, like adolescent or adult will be given who present with colorectal bleeding. Colonoscopy was done. This is a histopathological image. And next question will be, when should the screening start? So it should start at 20 to 25 years. Okay, next. Colonoscopy also removes precancerous polyps because it is a diagnostic plus therapeutic technique. So all these things I have discussed. Okay, next is one negative lifelong clearance. This means that one negative test doesn't rule out occurrence of carcinoma in high risk groups. Okay, So fit what it is, I have told you annually you should do it. Then you should stop at 75 years of age, and then colonoscopy. Okay. So next topic we are going is Crohn's disease. Crohn's disease and ulcerative colitis, very frequently things are there. So I have given you visualized mnemonic so that you will never forget these things. So in Crohn's disease, you can say there is patchy involvement. It can involve oral cavity also in the form of ulcers. It will involve rectum. It will involve large intestine, small intestine. Okay, so there is transmural, means entire wall thickness is involved, and there are granuloma formation. So non-caseating granuloma, if you remember what we studied in pathology, that occurs in the case of Crohn's disease. So it is transmural, that is full thickness lesion. Next, the mucosa appearance is cobblestone appearance. Okay, and because of this transmural involvement, there will be fibrosis and all, as a result of which stricture will occur. So stricture is typical of Crohn's disease. It is not typical of ulcerative colitis, because in ulcerative colitis only superficial layers are involved. Here deep layers are also involved. There is skip lesion. Skip lesion means it is not continuous. One side is involved, then there is normal intestine, then again one more side is involved. So these are called as skip lesions. Now what is this creeping fat? Creeping fat means because of these lesions, fat can go, mesenteric fat can go inside this. Okay, so that is known as creeping fat. And diagnostic feature on biopsy, what you will find? You will find non-caseating granuloma in case of Crohn's, and can also cause fistula, and from this fistula there can be bleeding also. In smokers, there is increased risk of Crohn's disease, but in ulcerative colitis, smoking is protective. Yes, you have heard it right. Smoking is protective in case of ulcerative colitis, but in Crohn's it increases. Now, because ileocolitis, that is ileum and colon is that junction is most commonly involved. This is also the junction where ileum is the junction where vitamin B12 is absorbed. So these patients will present with vitamin B12 deficiency also. So superficial lesion is ulcerative colitis, transmural lesion is Crohn's disease. So there won't be only bloody diarrhea, there can be only pain abdomen or acute abdomen. So don't just wait for blood in the stools. Okay. So treatment, you will use steroids along with that azathioprine and biologicals. Okay, that is anti-TNF agents. Now transmural is Crohn's, granuloma is Crohn's, skip lesion is Crohn's, fistula, cobblestone is Crohn's, continuous rectal involvement is ulcerative colitis. Okay. So initially there will be a genetic susceptibility which leads to granuloma, which leads to fibrosis, which leads to stricture. This is the whole pathophysiology, and here is the visual mnemonic to remember it. Going on to the next topic, that is diverticulitis. So what is diverticulitis? There are small outpoachings from the colon known as diverticula, and because of this obstruction or some inflammation happening over there, it leads to diverticulitis. There will be left lower quadrant pain, fever, and leukocytosis. Now this is actually counterpart of appendicitis, because in appendicitis there was right lower quadrant pain, and here it is left lower quadrant pain. Okay. And sigmoid colon is most commonly affected. So the cause here is fecalith obstruction, and CT is the preferred image. There is no colonoscopy because it is acute condition and it can lead to complications, it can lead to perforation and all. Okay. So what are the complications of this diverticulitis? One is abscess formation can happen, there could be perforation, and there can be fistula formation. So here low fiber diet has some beneficial effect. Now what is pneumaturia? Pneumaturia means because of the diverticulitis there can be fistula between the bowel, and there can be fistula between the urinary tract. Okay, that is between the bladder. So this is known as pneumaturia, which means there will be air bubbles in the urine. Air bubbles from the colon will go into the bladder, and this apple core lesion is not seen in diverticulitis. It is basically apple core lesion means when you do contrast study of the bowel, that is when you give barium enema. So you will see that because of the occupancy of the tumor, the contrast appearance will be like apple core. Okay, so like this. Okay, apple core, that is known as apple core. That is not seen in diverticulitis. It is seen in carcinoma of colon. Okay, and right-sided pain doesn't occur in diverticulitis. It is left-sided pain. Right-sided pain, think of appendicitis. Okay, next. Doing colonoscopy is contraindicated, because one of your option would be what is the next step of my management, and it will be colonoscopy, and you will tick on that. Okay, so don't do colonoscopy during that time. Okay, now what is the treatment? NPO plus fluids with the surgery if perforation has occurred. Okay, so commonest site is sigmoid colon. CT is the investigation of choice. Colonoscopy is not done. Left lower quadrant pain along with fever with CT showing abscess, diverticulitis, and right inferior right iliac fossa pain is not diverticulitis. Okay, so basically it is because of fecalith obstruction. So I think I have explained everything regarding this. Going on to the next topic, that is esophageal varices. We had discussed this in case of portal hypertension. So once there is cirrhosis, so there will be development of portal hypertension, and because of this there will be increased pressure within the portal venule also. So portosystemic collaterals will open because of this portal hypertension, and wherever there are portal system and systemic circulation collaterals, that is combining, collaterals means mergers. Okay, so there will be dilatation of those veins. So in lower one third of esophagus there will be dilatation of this short gastric veins, which will rupture and cause hematemesis. That is the basic pathophysiology. So most common site is lower one third of esophagus, and cirrhosis is the most common cause. Then comes schistosomiasis. Okay, now what is the emergency management? Emergency management is one is will give a bowel wash with the cold saline, will give octreotide. Okay, and you will do band ligation. So band ligation means you do endoscopy and you put a band around these varices and constrict them so that bleeding doesn't occur. Okay, so emergency endoscopy endoscopy and band ligation is the treatment of choice. Prophylaxis means what can you do to prevent further episodes of hematemesis? You will give non-selective beta blocker, that is propranolol is the drug of choice. So there are some other uses of propranolol other than usage in hypertension and in case of in case of hypertension. Other than that, propranolol is used in case of hemangiomas, okay, and second it is used in case of varices for prophylaxis, okay. Next, you have to avoid NSAIDs because it can cause gastritis, okay, and which can actually erode the esophageal surface, and hence propensity for hematemesis is increased. In case where there is contraindication for band ligation and all, what we do is for portal hypertension, we do TIPS. TIPS means transjugular, means you go through the jugular vein and then you create a bypass shunt which actually shunts the portal circulation. So directly from here, with this vena cava, directly will have connection to, from the lower circulation, that is inferior vena cava, you will have direct connection, okay. Yes. So other methods of treatment are, one is you will use balloon and inflate it. This is known as balloon tamponade using Sengstaken Blakemore tube. So you will insert this just like Ryle's tube and you will inflate it so that it will compress against the stomach wall and stop bleeding, okay, in the esophagus, okay. Next, using a nasogastric tube before controlling bleeding is not a good option because you are actually damaging the esophageal varices. Next, always think about airway also whenever patient is managed, because when patient has hematemesis, he can also have aspiration, okay. Next, drug of choice is octreotide. Shunt, if you have to do it, is TIPS, that is transjugular intrahepatic portosystemic shunt. Bleeding is more common in lower 1/3 of esophagus. Cirrhosis and hematemesis, think of varices, and peptic ulcer bleed will always be painful bleed. There is one distinction between peptic ulcer bleed and bleed of esophageal varices. Esophageal varices bleed is painless, peptic ulcer bleed is painful. Okay, so I have discussed everything. Yes, we'll go on to next topic, that is GERD. So next topic is GERD. A simple topic where you shouldn't lose any marks. So there will be transient lower esophageal sphincter relaxation, as a result of which there will be acid reflux. There can be regurgitation also in some cases, okay. So typical presentation is at night time when the patient is lying supine, and heartburn worsens when lying down, okay. So tell me in which this is pain increases on release on bending forward and pain increases when the patient is straight forward. Yes, that is pancreatitis, okay. Pancreatitis pain is epigastric. This GERD is also epigastric and chest pain, but this typically worsens when the patient is lying down. Next, the test of choice is this 24-hour pH monitor. So basically you connect esophageal in the esophagus, you connect this tube to which there is this pH monitor, and that will actually measure for over 24 hours, and this is the gold standard. So which are the alarming signs? One is dysphagia, weight loss, gastrointestinal bleeding. If these symptoms are there, then it can also point towards some malignancy, and hence we need endoscopy. Now, what are the complications? Barrett's esophagus. So what happens in Barrett's esophagus? There is intestinal metaplasia, which means squamous epithelium of esophagus is replaced by columnar epithelium. So what is the first treatment of choice? It is PPI, that is proton pump inhibitors. Now, rare thing is there is something called as hiatal hernia, where stomach wall actually herniates through the aperture in the diaphragm, okay. That is known as hiatal hernia. Next, this is associated with exaggerated GERD. So GERD can also trigger asthma and chronic cough, especially in children and even in adults, morbidly obese adults. Because of this GERD, they can have reflux, which actually irritates their throat. They can have aspiration, as a result of which they can have chronic cough. Also, using H2 blockers alone for Barrett's esophagus is a wrong option in your exam. So in Barrett's esophagus, there will be severe GERD symptoms, okay. So H2 blockers will only suppress the symptomatic part, okay. So it is used in mild to moderate cases, but in severe cases like Barrett's, we'll use proton pump inhibitors only. And alarming feature, these are the things you should ask whenever we should see in exams, whenever there is GERD, because this can point towards malignancy. Next, lifestyle modifications are to be done. I think you know that, I don't have to explain. And proton pump inhibitors can be given for 8 weeks. And if the case is refractory, then we go for fundoplication. So what is fundoplication? Fundoplication means around the fundus of the stomach we'll create a flap so that it gets constricted. This lower esophageal tone, this lower esophageal sphincter part will get constricted a little bit so that reflux will be less, okay. So it's a surgical management. So gold standard is pH monitoring, very good. Complication of GERD is Barrett's esophagus. Drug of choice is PPI. Nocturnal heartburn along with relief with PPI is GERD, and pain radiating to the jaw along with heartburn is not GERD, it is angina. Just remember these things, okay. Yes, I think I have explained everything. Going on to the next topic, that is gastroparesis. So gastroparesis means there is basically, what is paresis? Paresis means paralysis. So there is paralysis of gastric musculature. So as a result of which there is delayed gastric emptying. So food stays in the stomach itself. This is because of autonomic neuropathy. The nerve supply coming to the stomach is affected, autonomic nerves, which in turn is seen in because of diabetes mellitus. So diabetes mellitus is the most common cause of gastroparesis, followed by post-vagotomy. Post-vagotomy means vagotomy is a procedure. So vagotomy is done, it's a surgical procedure when there is a very excessive secretion of acid, that is severe gastritis. There a final procedure which was done earlier, that is vagotomy. So in vagotomy, post-vagotomy, what happens? Nerve supply to stomach is hampered, as a result of which we'll have gastroparesis. So what are the symptoms in this? One is early satiety, because gastric emptying is not taking place. Food here is not getting drained. Okay. So as a result of which there is early satiety, there is bloating sensation, and there is vomiting. Okay. So what is the diagnostic test? That is gastric emptying scintigraphy, which is diagnostic. Basically, scintigraphy means it's a radio imaging technique where you see where the gastric contents are. So suppose it is going into the intestine, then that means that there is normal gastric emptying. If the radionuclear contents are still in the stomach, that means the gastric emptying is delayed. So this is the test of choice. Okay. Now next, some rare facts is that this actually improves, gastroparesis improves if small volume meals are taken along with low fat meals. Okay, so that actually improves symptoms of gastroparesis. Short term motilin agonist can be given. Which motilin agonist is used? Motilin agonist is nothing but erythromycin. Yes, this is actually surprising because erythromycin is an antibiotic, but it is also motilin agonist. So this motilin agonist stimulates gastric emptying. Okay. Next, the drug treatment that is used is one is metoclopramide and domperidone, which both increase gastric emptying. So one complication is Bezor formation, where there is actually whatever food contents is eaten, it is still in the stomach only, and it doesn't get transferred to the small intestine. So next, don't confuse gastroparesis with mechanical obstruction. Mechanical obstruction means there is some tumor or there is some foreign body which is not allowing the stomach to, which is not allowing peristalsis. What happens in gastroparesis? There is no peristalsis at all, but in mechanical obstruction there is peristalsis, and this peristalsis is not happening smoothly because of this obstruction. Next, skipping dietary modifications will be also given in option, which is actually not the correct option because small volume low fat meals actually improve symptoms of gastroparesis. Okay, so I have explained everything. Remember, scintigraphy is a test used in case of gastroparesis. Drug we use is metoclopramide, and cause is diabetes. Okay, so this is the clinical scenario that you give. Important thing is endoscopy will be normal because there is no lesion which you can see from inside the stomach. It is basically the problem with the musculature of the stomach. Okay, so obstructive lesion doesn't cause this type of symptoms. So gastroparesis is not an obstructive lesion. Okay, so we'll go to the next part, that is Gilbert syndrome. So a very important topic. So Gilbert syndrome actually happens because of a decreased one enzyme activity, that is glucuronidation enzyme is defective, that is UGT1A1 enzyme decreased activity. Okay, so this is basically involved in conjugation of bilirubin, as a result of which we get unconjugated bilirubin, but these levels are not increased, like activity is decreased but it is not absent. Okay, so around 30% activity will be there, it is not completely absent. Hence in cases of stress where bilirubin is increased or liver is under stress, at that time patient will manifest as jaundice, otherwise there won't be any symptoms. Okay, so what happens is unconjugated bilirubin is metabolized by, not metabolized, it is glucuronidation of this unconjugated bilirubin yields conjugated bilirubin. Okay, now this defect is in this enzyme UDP glucuronidase transferase, that is UGT1A1 enzyme. Okay, so unconjugated bilirubinemia is what we get. So whenever there is fasting or stress or illness, that time jaundice will be there, otherwise everything will be normal. Important factor is AST and ALT are always normal, it is only isolated unconjugated bilirubin increase. Okay, that's why it is known as unconjugated hyperbilirubinemia only, nothing else. It is benign, it is asymptomatic, nothing is required. You should just avoid fasting because fasting induces hyperbilirubinemia, that is unconjugated. So it is seen normally in 5% of the population. Bilirubin is always less than 6. There is no need of treating this, and you shouldn't confuse this with Crigler-Najjar syndrome, where there will be less than 10%, that is around less than 1% also in some cases, which will present in neonatal period only. Okay, so this is a form of congenital hyperbilirubinemia. So I have explained everything, all this. So your first thing is enzyme, you have to remember which type of hyperbilirubinemia, what is the treatment, and there will be normally LFT and kernicterus in infant is seen in Crigler-Najjar syndrome, not in Gilbert syndrome. Okay, yes. Next, hemochromatosis. Now why we are studying hemochromatosis in GIT is because it affects liver mainly. So there is iron overload basically in hemochromatosis, and this iron deposition in various organs will lead to different manifestations. So what is the main cause? What is the etiology? Main cause is it is autosomal recessive mutation in HFE gene. Okay, HFE gene. So this HFE gene is involved in Yes, so what is the mechanism of action of this HFE and how is it related to hemochromatosis? When there's mutation in this, this actually encodes for hepcidin. Okay, hepcidin is one molecule, hepcidin, which actually regulates iron intake. So when there's mutation of hepcidin, whenever body has more iron stores, iron shouldn't be absorbed. But when this mutation occurs, body iron metabolism is not regulated, and hence more iron gets absorbed into the body. Now this deposits in three places. One is skin, one is pancreas, and third is in liver. So symptoms are also accordingly. One is bronze skin, second is diabetes mellitus, and third is hepatomegaly or cirrhosis also it can cause. Okay, what do you see on blood test? Ferritin will increase because ferritin is iron storage. Ferritin will be increased, transferrin saturation will be increased, but total iron binding capacity will be decreased because iron doesn't want to bind anymore to transferrin. Okay, so iron binding capacity will decrease, whereas TIBC increases in case of anemia because there is a lot of iron. TIBC decrease you will see in one more condition when there is iron overload, that is thalassemia, where you see decreased iron binding capacity. Okay, next, what are the complications and what is treatment? Basically it is phlebotomy. Phlebotomy means you let the blood go because you have more iron, you have more HB, that's why you let it go. And second is Deferasirox. Deferasirox means it's an iron chelator which is also used in thalassemia for iron overload state. It will chelate iron and hence decrease the symptoms. So complications are there is increased risk of 200 times for hepatocellular carcinoma after cirrhosis happens. Okay. Now, what are the other important things you should know? One is restrict vitamin C and alcohol because both of these increase absorption of iron. Second, there is something called as secondary hemochromatosis, which is not because of genetic. Genetic is primary. Second is because of other causes that can happen. Hemochromatosis can occur in other, iron overload can occur in other conditions also. That is called as secondary. Secondary hemochromatosis is not genetic. Next, serum iron alone doesn't tell you anything. Important is ferritin and transferrin saturation. Next, screen first degree relatives if you see any case of hemochromatosis because this is autosomal recessive. So gene involved is HFE gene, triad is diabetes mellitus, skin involvement it is bronze skin and liver cirrhosis. Third is treatment is phlebotomy, and along with that you give Deferasirox, and this is the lab investigation. And microcytic anemia doesn't occur because here there is iron overload. Okay, so I think I have explained everything. We'll move on to the next topic, that is hepatic encephalopathy. So when we were discussing acute hepatitis, I told you how liver toxin production is increased in the liver because there is no regulation. Liver can't detoxify things, as a result of which there is increased ammonia in the blood. This ammonia will cause changes in glutamine and glutamate. It will increase, and as a result there is neuropsychiatric syndrome because of this excitation of CNS and followed by depression. So this is the cause for hepatic encephalopathy. So there are various grading of hepatic encephalopathy. In grade 1 and grade 2 you will see initially confusion. In grade 2, that is stage 2 hepatic encephalopathy, you have this asteresis. Asteresis means when you ask the patient, it is flapping tremor. Ask the patient to hold his hand still, and then when you give a steady jerk, then there will be tremors. These are known as flapping tremors. This asteresis is asked in MCQ. This is hallmark of hepatic encephalopathy stage 2. Okay. In stage 3 there will be stupor, and in stage 4 there will be coma. So gradually there will be deterioration. So what are the precipitating things? Yes, one is GI bleed because of varices. Second is any infection can trigger it. Third is hypokalemia and constipation. So basically patient is in acute liver failure. That doesn't mean patient has gone into encephalopathy. Okay. So in acute liver failure there are two components. One is coagulopathy, and second, coagulopathy means the coagulation factors are affected, and as a result of which there is clotting factor derangement and there is bleeding. So one is coagulopathy which occurs in acute liver failure, and second is hepatic encephalopathy. Okay. So coagulopathy will measure using PT-INR and encephalopathy will measure clinically. So in this encephalopathy, in liver failure, for encephalopathy to occur there should be some precipitating factor, and these are the precipitating factors. Okay. So what are the treatment aspects you should know? One is rifaximin. Rifaximin actually is used to sterilize gut because there are some bacteria which produces ammonia. If this ammonia is decreased in the gut, then there will be decreased absorption of ammonia, and as a result of which ammonia in the blood is decreased, as a result of which hepatic encephalopathy features will decrease. Similar thing is done by lactulose also. Lactulose, what it will do is it will generate acids in the gut. Okay, so lactulose is broken down to form fatty acids. It is broken down to form some acids, and these acids will trap this ammonia in the form of NH+ because acids are H+ donors, and as a result of which ammonia is excreted, ammonium ion is excreted, and ammonia doesn't get absorbed because ammonia is converted into ammonium ions, and this decreases ammonia overall. Okay, so that is lactulose is used in hepatic encephalopathy. Now ammonia will be increased in the blood, but in CSF ammonia can be normal. This is an important INI-CT point. Okay, so ammonia can be increased in blood, but CSF ammonia remains normal. Next, in EEG, what pattern do you see? You see triphasic waves, okay? Triphasic waves pattern is seen in EEG in case of hepatic encephalopathy. Now, you shouldn't use sedatives in case of hepatic encephalopathy, especially don't use midazolam. Now, why are we even talking about sedatives? Sedatives because in hepatic encephalopathy, there will be a lot of confusion, there will be aggression, there will be altered behavior, as a result of which what everyone will do, they will give midazolam so that the patient is sedated, or if you want to intubate, will give. But the problem is this midazolam and most of the drugs, lorazepam and all, are metabolized by liver. They undergo hepatic metabolism, and when there is hepatic metabolism, already our liver is failing, okay? So as a result of which there won't be excretion, and as a result of which this will cause toxicity and it will cause CNS depression, it will further worsen encephalopathy. So sedatives are not used in case of liver failure. We don't use midazolam, which is commonly used as a sedative. Next, you should always search for precipitating cause, because maybe the patient is in hypokalemia, but you might have completely missed it out. And third is avoid protein over restriction, because people will think that more protein over, you should avoid protein totally, because if you avoid totally, then there won't be ammonia production. It is false. You should have protein restriction, but there shouldn't be over restriction. And next is correction of electrolytes is very mandatory. Most common is hypokalemia, because it can also precipitate and it is life threatening also. So drug we use is lactulose. Signs, which is this, asterisk is seen in grade 2 hepatic encephalopathy. Trigger is GI bleed, one of the triggers. Flapping tremor plus cirrhosis is HA stage 2, and focal deficits do not occur. It is a false statement, because it can occur later on, but initially there won't be any neurological deficit. There will be global CNS dysfunction. So I have explained everything. Yes, we'll go on to the next topic. Next, we'll go in brief with the viral hepatitis different types and how to differentiate everything, okay? So you should know that this is a healthy hepatocyte, and then viral infection will occur. It will cause inflammation of these hepatocytes. It can cause necrosis or inflammation. There can be two outcomes. So there can be two outcomes. One is you can have recovery, and second is in the case of hepatitis B and hepatitis C, it will go to a carrier state, and future it can go into cirrhosis, and then it will go into hepatocellular carcinoma. So now you should know few things. This table is very important. So HAV, hepatitis A virus, is an RNA virus. In entire thing, everything is RNA except hepatitis B, which is a DNA virus. So A and E are spread by fecal-oral route. A and E both are self-limiting. HAV, that is A virus, is most common in children. It is the most common cause of acute hepatitis in children, and hepatitis E is fatal in pregnancy. There is 20% risk of mortality in pregnancy. So there is no chronic state in A and E. So these are only acute hepatitis causing viruses. HBV is a DNA virus, which is most commonly spread through parental route and other routes also. It can be chronic, or it can go into inactive carrier state also. It has reverse transcriptase enzyme, and hence we get DNA because of this. Okay, reverse transcriptase enzyme is there. HCV is chronic hepatitis. More than 80% will go into chronic only, and directly acting antivirals. Okay, these are known as directly acting antivirals. This therapy will give for 3 months, and most of the cases it is curable also. HDV, that is hepatitis D virus, it occurs as a co-infection, which means if there is HBV, only then HDV occurs. Okay, so it is a defective virus. It is a dependent virus. Okay, it can occur only as co-infection or super-infection. So it is dependent on HBsAg. So with this in mind, if you ask me which is the most safest virus out of all this, I would say hepatitis C, because if you see a case of hepatitis C in children, we don't treat it because the duration it takes for this virus to cause cirrhosis and chronic like hepatocellular carcinoma, it's like around 30 to 40 years. It is very long term, slowly damaging type of thing. Okay, so it has only 3 months treatment duration also. And the most dangerous out of all this is HEV and HAV, because it can cause life threatening disease. I have seen people, children dying of hepatitis A virus infection. Okay, because it is so rampant. Mortality is just 1%, but the infection rate is very high. So we'll see some rare facts. So HBV, hepatitis B virus, has reverse transcriptase. HEV in pregnancy I have already told you. Vaccines are available only for HAV and HBV. Okay, for HCV we use directly acting antivirals, and it is curable. Now these things I don't have to explain again. Now this also I don't have to explain. Okay, next, HCV is chronic in most of the cases, true. HEV is fatal in pregnancy, which is true. HDV is dependent on HBsAg, which is true. If RNA fecal-oral route, it is self-limiting. If DNA parental, it is chronic. This is true for HBV. Okay, so I think I have explained everything that is required. We'll also visit this once during microbiology. Next topic is hepatocellular carcinoma. So hepatocellular carcinoma risk factors I told you just now: HBV and hepatitis C. Then cirrhosis, then aflatoxin. Aflatoxin is related to fungal infection. Okay, fungal toxin. Okay. Next, AFP. So in hepatocellular carcinoma, one important tumor marker that is increased, that is AFP, or alpha fetoprotein. Okay, AFP is nothing but alpha fetoprotein. Okay. So on imaging, what will you see? You will see this arterial enhancement plus washout, which means we'll do triple phase CT. Triple phase CT. Okay. Triple phase means first we'll take image when there is no contrast. Second, we'll take CT immediately after contrast, and third will take CT a few minutes after contrast. So in imaging, you will see arterial enhancement followed by washout. Means in the first, so I told you about three phases. So initial first phase is when there is arterial phase, which is the earliest phase, where the tumor becomes enhanced immediately when the contrast is given into the arteries. In second phase, that is it is venous phase, what will happen? The contrast will decrease, okay? And in third phase, that is post-delayed phase, the contrast will be further decreased, okay? It will become hypodense. So this type of pattern is seen only in hepatocellular carcinoma, and hence we have this separate name for it. So how does hepatocellular carcinoma spread? Spread is via hematogenous route. I told you, right? Sarcomas and sarcomas, that is soft tissue tumors, and epithelial tumors. So epithelial tumors, which are carcinomas, they spread through lymphatic route, and sarcomas, that is soft tissue tumors, they spread through hematogenous route. So this is a sarcoma. So it's type of sarcoma, which is a soft tissue tumor. Okay, so it spreads through this hematogenous route. Okay, so most common metastasis zones are lungs and bones. So screening in high risk cases is done 6 monthly. So basically people who have these infections, cirrhosis, will do screening, and it is done using USG along with the AFP, that is done 6 monthly. Okay, and this thing I had covered in pathology also. So in imaging, you will get arterial enhancement and washout during delayed phase. Okay, just remember this much. So what are the various pathophysiologies? One is HBV, HCV we saw, and third is it can arise in cirrhosis also. Next, what are some rare things? HBV causes carcinoma by integrating its X gene. Okay, X gene is important. That is actually the tumor causing gene into the DNA of this hepatocytes. So this is the mechanism of oncogenesis when it comes to hepatitis B. Now, transplant is planned only if there are less than 3 nodules which are less than 3 cm each, and this is known as Milan criteria. So in your question MCQ, the question will be based on what Milan's criteria, which of the following is true, and the options will be like less than 3 nodules, more than 3 cm. So you should have less than 3 nodules and it should be less than 3 cm. Okay, then we'll go for transplant. Next, CA 1999 is actually useful in pancreatic adenocarcinoma and cholangiocarcinoma, which we have already discussed in pancreas. It is not for hepatocellular carcinoma. And EFP is not specific. It is mainly used for screening test only. So what is specific? The CT, that triple phase arterial enhancement along with washout, that is very specific. Marker is AFP, causes hepatitis B virus, spread is via blood, that is hematogenous. Cirrhosis along with increased AFP, you should think of hepatocellular carcinoma, and CA19-9 is not seen in this case. Okay, so curative is either resection or transplant, and indication for transplant I have told you already. So here you will see this triple phase. So initially there will be arterial enhancement. So here you will see enhancement. Then this is the venous phase, and then this is the delayed phase where the lesion becomes hypodense. Okay, yes. So now we will go for one more important topic which we had discussed earlier also. Crohn's disease we had seen. Now we'll compare it with ulcerative colitis. So in inflammatory bowel disease there are two types: ulcerative colitis and Crohn's disease. So first thing is depth. Okay, I told you Crohn's disease is transmural, as a result of which we'll have stricture involvement, but ulcerative colitis it is superficial. Okay, only involves epithelial layers. Next, distribution wise it is continuous. Ulcerative colitis. Crohn's I told they are skip lesions. Okay, here and there it will come. Next, granulomas are seen in Crohn's disease. I told you non-caseating granulomas. Next, blood in stools is seen more in case of ulcerative colitis. You see here the whole colon is inflamed and it is superficial also. That's why more chance of blood in stools is seen in here. In Crohn's disease it is occult blood. Cancer risk is higher with ulcerative colitis than with Crohn's disease. And yes, I think rectal involvement is seen most commonly in case of ulcerative colitis. Okay. Okay, some other things are ulcerative colitis has association with PSC. So what is PSC? PSC is primary sclerosing cholangitis. Okay, primary sclerosing cholangitis. So this association is there with the ulcerative colitis. And second, Crohn's disease B12 deficiency occurs. That is because involvement of ileocecal junction. I have already discussed this. Okay, I have told everything. Yes, everything is done. Yes, treatment is 5 ASA in case of mild inflammatory bowel disease. In case of acute flare, we give steroids, and then we go for biologic like infliximab, TNF alpha antagonist. Okay, so for that we'll go. Okay, so it is a step up approach. We'll start with mild and then we'll go higher. So this is ulcerative colitis where you see pseudo polyps. Okay, this is a colonoscopy image, and Crohn's disease you will see cobblestone appearance. So these images you should be able to identify in your exams. Next we'll go to something known as IBS, which many people actually, that is IBD. This is IBS, which is irritable bowel syndrome. This is not inflammatory bowel syndrome. This is irritable bowel syndrome. And from this, every time one or the other question is asked regarding this Rome 4 criteria. You take any medicine paper of NEET PG, you will get one definite question on this Rome 4 criteria, and that is what we'll be seeing today. So irritable bowel syndrome is basically dysfunction in the gut-brain axis. Okay, so gut means stomach and brain. There is a neurological connection. Okay, so dysfunction in that. So there is basically a change in motility, and the most common thing that is seen is the pain. Irritable bowel syndrome is pain or discomfort, which gets related with defecation. Okay, so this is the most common exam indicator, MCQ indicator. So we use Rome 4 criteria, and in this symptoms. Symptoms should be present. What are the symptoms? It can be either constipation or it can be diarrhea or mixed. Or it can, these are the most common symptoms. Okay. So either constipation or pain abdomen or diarrhea, these should be present for more than 1 day in a week, and it should be present for more than 3 months. So this is the diagnostic duration. Okay. So this pain or this discomfort, it shouldn't be accompanied with other red flag signs. So what are the red flag signs? There shouldn't be change in stool consistency. There shouldn't be change. There shouldn't be any bleeding. There shouldn't be weight loss, and there shouldn't be any other organic cause. These three things, main red alarm feature shouldn't be there. And this pain or discomfort will be associated with change in stools, and it will be relieved with defecation. So these are the red flag signs, and these are the symptomatology. So on colonoscopy, everything will be normal. Females are a little bit more affected than males. So most common differential is IBD, which you'll think, but IBD will be accompanied by its own set, like weight loss. There will be bleeding, that is rectal bleeding, or there can be hematochesia. Okay, and investigating aggressively if there are no red flag signs is the wrong MCQ option, because if there are only red flag signs, then you investigate, or else we'll just treat it as IBS. Okay. So what is the dietary restriction? You should do FODMAP. What is FODMAP? So FODMAP means fermentable, oligosaccharides, disaccharides, monosaccharides, and polyols. So these are the things that patients should avoid. What is the logic behind this? Oligosaccharides means all these are type of sugars. Okay, so oligosaccharides you'll see in wheat, barley, rye, and all. Disaccharides is lactose, basically milk products. Monosaccharides is fructose, like for example in fruit juices and all. And polyols are like sorbitols, artificial sweeteners, all come under sorbitol. So what happens is, in this case, this lactic acid is produced, and along with that H2 gas is also produced. Okay, and this gas accumulation, okay, this fermentable gas accumulation actually causes distension of the bowel slightly, but brain thinks that as it just over the pain pathways, that actually gets overwhelmed. Okay, so that's why, because that is because of gut brain axis only, it will perceive it as a higher stimulus. So that is the everything related to this IBS. Okay, that gut brain axis dysfunction. Along with this, psychotherapy will also help. Relieving stress and all actually helps. So pain relieved by defecation is an important clue in your MCQ. Normal investigation is an important clue. There shouldn't be any of these red flag signs, and it's a functional disorder. Colonoscopy will be normal, relieved after stool, and blood in stools means it is not IBS. Okay, so I have explained everything. Yes, next we'll go to jaundice, basic things. Okay, what we'll see in physiology. So jaundice occurs, there are three types I have told you. One is pre-hepatic, hepatic, and post-hepatic. Pre-hepatic is because of hemolysis, unconjugated bilirubin will be there. Parenchymal injury, if it is there, it can increase both conjugated and unconjugated, and if there is obstruction post-hepatic, then it will increase only conjugated bilirubin. Now RBC, pre-hepatic, unconjugated, so there won't be any bilirubin in urine and stool. So there is no urobilinogen, there is no stercobilinogen. That is because unconjugated bilirubin is not converted into conjugated one. So main reason is hemolysis in this case. And second is in case of neonatal jaundice. Second is in hepatic jaundice, some liver damage has occurred. There will be mixed picture. You will get mild, you will get stercobilinogen will be increased and urobilinogen will be increased. And in case of post-hepatic, where there will be obstruction to the bile duct or biliary tract, there you will get conjugated bilirubin increase along with the increased urobilinogen along with stercobilinogen. But the stools, stools will be pale stools. Okay, and there will be pruritus. These two are important things. Pale stools along with pruritus is an important clinical symptoms in MCQ, and increased ALP, that is alkaline phosphatase, more than ALT, that is SGPT, is typical of obstructive pattern. And remember, this ALP increase to be significant, it should be more than 4 times. Okay, because in many conditions such as pregnancy, for example, in those conditions also ALP will increase significantly. Even in some cases like rickets, okay, rickets also will see increase in ALP, because ALP synthesis also occurs in the bones also. Okay, so any bone disease or liver disease, you will see increased ALP. It is not very specific, but it's an indication that something is wrong with the either biliary tract or the bones. So painless obstructive jaundice is seen in case of carcinoma head of pancreas in adults. So remember this MCQ pointer. Similarly, pruritus occurs because of bile salt deposition. Okay, it is not because of any neurological issue. So all these things I have told you. So you'll do USG first, and then for bile duct related lesions, you'll do MRCP or ERCP. So all these things I have explained, I won't go to those again. Okay. Next we'll see Mallory-Weiss tear. So when there is repeated vomiting and repeated retching, what is retching? Retching is a feeling of vomiting which precedes expulsion of content. So that is called as retching. That will cause mucosal tear at the gastroesophageal junction, because of which there will be hematemesis, and it is usually self-limiting and it will spontaneously heal. So hematemesis, painful hematemesis after repeated bouts of vomiting, it should make you think of Mallory-Weiss tears. So there will be mucosal laceration, most commonly seen in alcoholics and bulimics, in anorexia nervosa and also in bulimia. You will see the patient will take more food, and then they will vomit it out, as a result of which there will be repeated vomiting and mucosal tear at gastroesophageal junction. Okay, so we'll have to differentiate it from Boerhaave syndrome, where there will be full thickness tear. Here there will be only mucosal. So Boerhaave syndrome is basically, you will see here, it is full thickness rupture along with mediastinitis. So you shouldn't insert NG tube in this because it can actually lead to complication, because there is already full thickness tear. Okay, so it is spontaneous transmural full thickness rupture of the esophagus after forceful vomiting or retching only. Cause is the same. Mallory-Weiss tear is superficial, but Boerhaave syndrome is full thickness tear, and because of this, contents will lead into mediastinum. That's why it will lead to mediastinitis also. Okay, and along with that, it can lead to subcutaneous emphysema also. Okay. Yes. So next we'll go to non-alcoholic steatohepatitis, which is now known as MASH, metabolic associated steatohepatitis, which is basically a complication following fatty liver. So this metabolic associated steatohepatitis initially starts because of metabolic syndrome. Okay, so there will be obesity, centripetal obesity, diabetes mellitus, hyperlipidemia, and then associated with hyperuricemia also. So initially liver will be healthy, then it causes fatty liver, which is known as steatosis, which is nothing but fat deposition in the liver. Then inflammation sets in, then it is known as steatohepatitis, and finally it leads to fibrosis, then leads to cirrhosis, then leads to hepatocellular carcinoma. Nowadays in Western countries, this is one of the most common leading cause of liver cirrhosis, other than alcohol. Okay, so most common causes: obesity, type 2 diabetes mellitus, and dyslipidemia. Here what happens is ALT is more than AST, and ALT is just 2 to 3 times of upper limit of normal. Okay, so in alcoholic liver disease, AST is more than ALT. So on histology you will find ballooning of hepatocytes because of fat deposition, and you'll find Mallory-Denk bodies. Just remember, these are Mallory-Denk bodies. Now ALT will be increased than AST. Okay, so ALT will be somewhere around 60 to 120, in those ranges. Okay, cirrhosis will occur and later will convert into hepatocellular carcinoma. What is the treatment? Lifestyle treatment is the first thing. Lifestyle changes, weight loss. Pioglitazone is one therapy which is advocated, and one more is vitamin E. So pioglitazone and vitamin E, these two drugs that also are given in later stages only, once steatohepatitis sets in. So one more is bariatric surgery, so that in refractory cases we go for bariatric surgery as a procedure for weight loss. So it is reversible if it is caught early, and there is no specific FDA approved drug. These both are just given based on some case reports. Okay, it is not FDA approved yet. Yes, I think I have explained everything. These are the common things that you must know about MASH. Okay. Next, coming to pancreatic cancer, adenocarcinoma, we had covered this in pathology also. So here I am not going to cover. Please watch it from pathology. Next, we have peptic ulcer disease. Say GERD is reflux of acid. Okay, so peptic ulcer disease is where ulcerative lesions occur in the stomach, inside the stomach. Okay, or in the duodenum. So duodenal ulcer can also be there. There can be gastric ulcer also. Duodenal ulcer is most common near the duodenal bulb. Okay, it is most common. And second site is gastric lesser curvature. Okay, lesser curvature of the stomach. So this is the most common site. Second is this, that is gastric lesser curvature. Most common cause is H. pylori followed by NSAIDs and then stress induced. So what happens is, because of this H. pylori or stress, or because of NSAIDs, there is increased acid production, there is increased pepsin production, and then there is decreased mucus production. As a result of which, mucus acts as a protective barrier that will decrease, and pepsin and acid will increase. These both will cause increased acid secretion, damage to the and erosion of the gastric epithelium, and hence this peptic ulcer disease. So typical complaint, how to differentiate between a gastric ulcer versus duodenal ulcer? Gastric ulcer will increase after meal, because food goes inside the stomach. Now it will cause erosion and it will cause more acid secretion. Whereas in duodenal, pain will decrease after meals. Okay, so pain decrease after meals is duodenal, pain increase after meals is gastric. Now how do you diagnose? There are some non-invasive gold methods. One is urea breath test. Basically, this H. pylori will produce the concept behind the urea breath test is this H. pylori will produce lot of urease enzyme, and when you give urea, this will break down urea this urease enzyme breaks down urea, and this urea is detected in the breath. Okay, so this is one of the diagnostic tests. One more is stool antigen, that is H. pylori antigen urine test. Okay, so these are non-invasive gold standard tests. What are the symptoms? Bleeding can occur, perforation can occur, even obstruction can occur. Gastric ulcers require biopsy, because even in gastric malignancy, that is adenocarcinoma of stomach, also ulcers can happen. Okay, we'll see this in surgery. So stress ulcers means it is known as curling ulcers, and CNS trauma ulcers are known as Cushing's ulcer. So whenever there are burns, okay, so there will be gastric ulcer formation because of stress induced. So that is known as curling ulcer, and Cushing's is related to CNS. Okay. Now acid secretion, the diagnostic clue is in gastric acid, acid secretion will decrease in case of gastric ulcers, and in duodenal gastric acid will increase. Okay. Next, what are the rare facts? H. pylori will utilize urease, and that is the like basis behind this urease breath test. Next, when patient is on proton pump inhibitor, then there is no point in testing for H. pylori, because you have already started therapy. NSAIDs will decrease prostaglandin synthesis, so it will decrease this mucus. As a result of that, the barrier is lost, and hence it will lead to increased ulceration. So confusing pain timing patterns is the most common mistake that students make. That is, the pain that increases with meals is gastric ulceration. Pain that decreases with meals is actually duodenal ulcers. Okay, so that is what this is. Pain will increase when the food is not there, that time pain will increase, that is duodenal. When food is not there, that time pain will decrease, that is gastric. Okay. Next, pain relieved by food is duodenal, pain after meals is gastric. Best test is urea breath test. This I have told you. If NSAID user, then think of gastric ulcer. Okay. In case of refractory ulcer, also think of one syndrome known as Zollinger-Ellison syndrome, where there will be increased gastrin secretion. Gastrin is a hormone. It is seen typically in men's syndrome. Okay, in men's syndrome, and in some form of tumors, you will see this increased gastrin secretion. It is known as Zollinger-Ellison syndrome. There you will see multiple gastric ulcers. So stop NSAID, stop smoking. These both will increase ulcers. And test of curve only in high risk. That is test of cure. Means doing endoscopy and looking for ulceration, biopsy, those are only in high risk patients. Okay, so these things are very important. Next topic is portal hypertension. I won't go into this topic again, because I have already discussed triad. I have discussed everything which is required. Okay, only few things which I have not discussed is, one is what is the pressure changes. So normally it is up to 5. If it goes more than 12, then we call it as portal hypertension. Okay, so portal hypertension is associated with the portosystemic shunts, splenomegaly, and ascites. This is the triad of portal hypertension. Okay, so more than 12 is portal hypertension. So this is cirrhosis, and so portal pressure definition is more than 5. Okay, by definition portal hypertension, portal pressure more than 5, and critical value is more than 12. Okay, so common causes cirrhosis. There are prehepatic causes, intrahepatic, and posthepatic causes of portal hypertension, which means something which is prehepatic. Okay, this is prehepatic, this is hepatic. Something happens here, like cirrhosis is hepatic because some problem is with the liver, and as a result portal hypertension occurs. But even portal vein thrombosis, this is the portal vein. Now here if thrombosis occurs, it is before the liver, right? So this is prehepatic. Now you will tell me, why is this not prehepatic? Why isn't this posthepatic? So actually there are two forms of relations here. One is with relation to the digestive tract. So if you consider this as blood source, this as the liver, and this as the bile duct from which bile is going out, then in case of jaundice this is true. Okay, then we call it as prehepatic, hepatic, and posthepatic jaundice. But here the relation is with relation to portal vein. That's why prehepatic means whichever comes into the portal vein, that is anything before the liver. That is this area, whatever happens, that is prehepatic. This is hepatic, and whatever happens in the post-hepatic is especially in the inferior vena cava, which happens above. Okay, so for prehepatic we have portal vein thrombosis and splenic vein thrombosis. In hepatic, intrahepatic we have cirrhosis, and post-hepatic we have Budd-Chiari syndrome, which occurs in inferior vena cava or it occurs in the hepatic vein. So this is the portal vein, hepatic vein is above, hepatic vein drains into the inferior vena cava. Okay, so that is the difference which you should know about. Now what are the collaterals which are seen? It can be either esophageal collaterals, varices, it can be rectal, and hence hemorrhoids are common in portal hypertension, and one more is this caput medusae, which occurs because of this portosystemic shunt. Now hypersplenism can also occur, as a result of which there will be sequestration of RBCs leading to and platelets leading to pancytopenia. So splenomegaly along with pancytopenia can also be seen in portal hypertension. So one important characteristic that is required in portal hypertension is whether it is that is portal hypertension indicator is SAG ratio. So what is SAG? SAG means serum albumin minus ascitic albumin gradient. So basically we are saying whether the ascitic fluid is rich in protein or not. So this will help us to differentiate whether there is portal hypertension or not. So remember this SAG ratio, it can be more than 1.1 or it can be less than 1.1. Okay. So always in portal hypertension means what? There is increased tension. So remember, always increased value, that is increased more than 1.1 means it is seen in case of portal hypertension. Okay. So increased more than 1.1 is portal hypertension. If it is less than 1.1, that means it is seen in other conditions also. Okay. So like for example, tubercular peritonitis, okay, TB of peritonitis, or malignancy in peritoneum or in peritonitis. So local causes is what causes SAG ratio less than 1.1. More than 1.1 is seen in portal hypertension and various other causes related to portal hypertension. Now portal thrombosis is very important. It is not post-hepatic, it is pre-hepatic, but Chiari is post-hepatic, where there is thrombosis in the hepatic vein. So what will happen is, this is the portal vein, and this portal vein will branch, and then it will form sinusoids, capillaries, and from these capillaries which venules will arise now, this will form the portal vein, and this portal vein, hepatic vein, and this hepatic veins, they will actually drain into the inferior vena cava. So what happens is, at the place where hepatic vein drains to the inferior vena cava, there will be some web formation, there will be congenital webs, or there will be some congenital obstruction, or it can cause because of thrombosis also. So that we call it as Budd-Chiari syndrome. Okay, so that is Budd-Chiari syndrome, which is a type of post-hepatic portal hypertension. So remember that splenomegaly is not always equal to portal hypertension. For portal hypertension, we should have ascites along with opening of portosystemic shunts, because splenomegaly can be seen in wide variety of conditions. It can be seen in malignancies like CML. It can be seen in malignancies like it can be seen in autoimmune conditions. It can be seen in malaria, infections like brucellosis, typhoid. In many cases, splenomegaly can be seen. So only splenomegaly doesn't indicate anything. It is just a symptom. It's just incomplete diagnostic clue. Missing HPPG threshold means hepatic vein pressure gradient. Okay, so that is 12. I told you, more than 12 is portal hypertension, and by definition more than 5 is portal hypertension. So confusing ascites etiology is also important, because ascites can occur because of two reasons. One is local causes, like for example peritonitis, or tuberculous ascites, okay, TB. All these are infection of the peritoneum and the surrounding structures which can cause ascites, or even nephrotic syndrome. Okay, these are the local causes. Then there are causes related to the liver. Those are related to portal hypertension. Okay, those are related to portal hypertension. Next, what is the treatment for ascites? It is basically salt restriction, because you don't want more third space accumulation, which means you don't want more fluid to accumulate in the abdominal cavity. And second is this spironolactone. Spironolactone is a diuretic, which is a potassium sparing diuretic. The reason is because in case of portal hypertension and ascites, it occurs because of cirrhosis, right? And we saw that in cirrhosis there can be risk of hepatic encephalopathy if it goes into acute liver failure. Now hepatic encephalopathy precipitating factor is hypokalemia. Okay, so hypokalemia can precipitate. So we don't want any diuretic which causes hypokalemia, which in turn can precipitate hepatic encephalopathy. So we want some potassium sparing diuretic, and that's why we use this spironolactone. In case of variceal bleed, we use non-selective beta blocker, that is propranolol. Okay, and in case of tense ascites, massive ascites, we do paracentesis, which is basically drainage of the peritoneal fluid. Okay, so I think I have explained almost everything here. This diagram shows which are the collaterals, and this splenomegaly on USG. Okay, yes, I have explained almost everything related to portal hypertension, and you shouldn't commit any mistakes with this. So primary biliary cholangitis and primary sclerosing cholangitis. So it is PBC versus PSC. Okay, so what are these two things and how to differentiate these two things? Because next we'll be going through primary sclerosing cholangitis in the next slide. So in primary biliary cholangitis, it is autoimmune basis. Okay, so it is autoimmune destruction of intrahepatic bile ductules. Okay, so there is chronic cholestasis along with this. So it is mainly seen in middle-aged women who present with pruritus before jaundice. This is the MCQ indicator which will come in your papers, that is pruritus which occurs before jaundice. Okay, and associated with this, when you do lab test, you will see LFT pattern in which there is ALP, which is cholestatic pattern, and AST ALT will be lower only than ALP. So when you do antibody test, that you will see anti-mitochondrial antibody, that is AME, anti-mitochondrial antibody is positive, which is the diagnostic hallmark of primary biliary cholangitis. So AMA along with ALP elevation is confirmation, and associated features are Sjogren's and rheumatoid arthritis, because this is an autoimmune disease, so you will have link with autoimmune diseases. And then you will have lipids, that is xanthelasma and hypercholesterolemia, which is also a clinical clue in this. And treatment is UDCA, which is used for cholestatic jaundice. Complication is cirrhosis, portal hypertension, liver transplant, all this. So basically what will be your exam scenario? A middle-aged woman who presents with pruritus followed by jaundice, who had prior history of rheumatoid arthritis or Sjogren's disease. LFTs were deranged. ELP was raised, which shows cholestatic pattern, which is which is the investigation of choice. The investigation of choice becomes anti-mitochondrial antibody along with the ALP elevation. Okay, and treatment is UDCA. This is the only thing that you need to know. What is the pathology lesion that you see? In pathology, you will see histopathology, florid duct lesion, okay, which is the hallmark. Florid duct lesion, just remember this much. And don't confuse this with PSC. In next video, that is next slide, that is primary sclerosing cholangitis, I'll tell you what PSC is. And one important feature here is marked HDL elevation, okay. We don't see good cholesterol elevation in any case. Here is one specific disorder where you see marked HDL levels, okay. So what is the treatment? Also, you will give supplements of fat soluble vitamins, and you will assess bone density, because this will cause fat malabsorption. Okay, so all these things I have discussed. We'll go to next differentiating option in your exams, that is PSC. So this is a fibro-inflammatory process where there is stricture formation in the bile ducts. Okay, so that leads to cholestasis. So here there was autoimmune destruction of the bile ducts, and here there is stricture formation because of chronic fibro-inflammatory process. So this is basically seen in young males, and LFT pattern is of same pattern. There is no much distinction, except that this has intra plus extra hepatic ducts are affected. You saw that in primary biliary cirrhosis only intrahepatic ducts were affected, but in primary sclerosing cholangitis here intrahepatic bile ducts along with extrahepatic are also affected. This is a strong link with ulcerative colitis. When in my ulcerative colitis slide I told you how it is associated with PSC. Okay, so on ERCP, that is endoscopic retrograde cholangiopancreatography, which is used for diagnosis, and it is used for it is a treatment of choice also, because at the same time you can diagnose also using ERCP, and you can also treat it also. Okay, if there are any strictures, you can open it if it is causing some symptoms. Okay, MRCP is preferred because it is non-invasive. ERCP is invasive. Basically, in ERCP you put endoscope inside the pancreatic cholangiopancreatic duct, and in MRCP you don't put anything. You just put the dye, and then you take magnetic resonance image. Okay, so what is the complication of PSC is cholangiocarcinoma. Okay, there is nothing else. So here P-ANCA antibody is positive. There what was positive? AMA, that is anti-mitochondrial antibody, and here P-ANCA. So P-ANCA is what? P-ANCA is also seen in vasculitis, small vessel vasculitis. Okay, there also you have got P-ANCA, like in MPA, okay, microscopic cholangitis, and some other vasculitis, you will get P-ANCA positivity. So liver transplant is the only curative option. There is nothing else, and you will have to use CA99 for monitoring of cholangiocarcinoma. I told this also. CA99 is used for pancreatic and cholangiocarcinoma monitoring. Okay, next. Onion skin beading is seen in PS in histology pattern. Okay, I think the image is not there. In histology, you'll see onion skin type of lesions. Okay, so in males it is PSC, in females it is PBC. So some things are, it will be early on, it will be asymptomatic, there won't be much symptoms. Pruritus precede LFT rise, just like PBC. Okay, asymptomatic presentation will be more common. Okay, and avoid ERCP unless it is therapeutic, because you don't want to introduce invasive procedure. Okay, you don't want to introduce endoscope inside the pancreatic duct. Okay, because it can lead to other complications like pancreatitis or duct injury, bile duct injury and all. Cholestyramine is a drug which actually relieves pruritus in this case. So ERCP bleeding is seen in PSC, ulcerative colitis association, PSC, complication cholangiocarcinoma, male patient with ulcerative colitis with increased ELP, think of PSC, AMA positive is PBC, and multifocal strictures are seen in case of PSC. Okay, so this is the process. There is some inflammation followed by fibrosis, stricture, cholestasis, cirrhosis, last unit liver transplant. So this is very important differentiating factor between PBC versus PSC. Okay, next, the screening for colon cancer. Okay, I'll just tell in depth. This question has been asked many times, that's why. So colon cancer, first there will be pre-malignant lesion, that is adenoma, followed by dysplasia, then you will have carcinoma. So the standard guidelines say that if there is average risk, then you have to start screening for colon carcinoma at 45 years of age using colonoscopy, which is gold standard, which is to be done every 10 years. Okay, then this FIT test. FIT means fecal immunochemical test, that is done annually and it is non-invasive. CT colonography that is using CT scan, okay, that is done every 5 years, okay, alternatively. This is the alternative for colonoscopy. So in high risk, and if there is family history of familial adenomatosis polypoic, or if there is a history of any colorectal carcinoma, then you start at 40 years or 10 years before the index, okay. So this is what you do. Next, you should stop by 75 years, because after that there is no need of screening. You should know that in right-sided carcinoma, right-sided colon carcinoma, there will be iron deficiency anemia and occult bleed. In left-sided, there will be features of obstruction, okay. Next, aspirin lowers the risk of colorectal carcinoma, we have told already. Lynch syndrome is associated with proximal tumors, okay. So Lynch syndrome we has seen in pathology also. So there is a mutation in these genes which actually causes MSH genes, okay, MSH genes, which actually causes multiple tumors. Then FAP is nearly 100% risk for colorectal carcinoma. FAP means familial adenomatosis polypi. There is no role of fecal immunochemical test during active bleeding, okay, remember this thing. And you shouldn't rely on this FIT test to exclude carcinoma, it is just a screening test. So all these things I have explained. Iron deficiency anemia, then do right colonoscopy, see for right colon colorectal carcinoma, okay. Yes, I think I have explained everything. We'll move on to the next topic, that is spontaneous bacterial peritonitis. It's a complication of ascites basically. So infection of ascitic fluid is actually SBP, where you don't find any source. So commonly there will be cirrhosis associated with the ascites. There is no intra-abdominal source, which means there is no perforation, and that after that it is not causing peritonitis, or there is no trauma or anything. So spontaneously it is happening. There is no other cause which is identified, and infection of the ascitic fluid occurs, okay. So what is the definition of SBP? SBP definition is there should be more than 250 polymorphonuclear cells, which are neutrophils. More than 250 neutrophils should be present in the peritoneal fluid. That is a diagnostic. When you do ascitic tap, that time there should be more than 250 neutrophils. That is the the definition of SBP, okay. Which is the most common organism? It's E. coli followed by Klebsiella, then it is Streptococci. So what is the presentation? The patients will have fever, along with that pain abdomen will be there. There can be encephalopathy secondary to cirrhosis, and because it can precipitate, this SBP infection itself will precipitate hepatic encephalopathy, and there will be decreased protein, and because of decreased liver synthesizing capacity. When you do ascitic fluid analysis, which is first line of management, that is first line of investigation, you do ascitic tap and you do microscopy of ascitic fluid. Then you send for culture. Culture is always negative. Okay? Often it is negative. There won't be much role of culture in this. However, you will see more of neutrophils in the ascitic fluid. So treatment is cefotaxime or cefoceftrazone, which are third generation cephalosporins, IV cephalosporins, and albumin infusion is given in case of massive ascites. Okay, so rare complications are, rare things are like fungal peritonitis, which is very rare, only in immunocompromised individuals. Second is there can be monomicrobial SBP also. So there are different types of SBP. I think I shouldn't go into that much depth. Okay, so next is some patients may be asymptomatic, and yeah, I think I have explained all this. Okay, next. What is the cutoff rule? 250 rule. Okay, next. Polymorphonuclear cells, more than 250 is SBP. Drug of choice is cefotaxime. Adjunct is albumin, prevents hepatorenal syndrome. If cirrhosis along with fever is there, then you do ascitic tap. Then if there is neutrophil threshold is met, then you will have to treat immediately with the IV antibiotics. There is high mortality without early therapy. Repeat paracentesis is considered if there is like repeat paracentesis is done if there is no improvement, and prophylaxis should be given so that next episode doesn't occur. Okay. Now important thing is what is this hepatorenal syndrome. So hepatorenal syndrome is because of liver failure, renal failure occurs. Okay, that is known as hepatorenal syndrome. So in case of SBP, where there is liver failure, because of this liver failure, there will be acute kidney injury, okay, AK develops. That is known as hepatorenal syndrome. You don't have to go much into depth. Next topic is travelers diarrhea, a very important question from microbiology. So the pathogenic agent for travelers diarrhea, as seen in the image, travelers diarrhea is nothing but a person travels, and because of that he'll have infection because of traveling only. So typically occurs 3 to 7 days after travel, and it is because of this enterotoxigenic. So this is not directly invasive. Invasive means directly microbe goes into the cells, intestinal cells, and it destroys the cell. It is not like that. This is toxin. Toxin is released by this enterotoxigenic E. coli, and that goes and it this toxin causes secretory type of diarrhea. So there is watery diarrhea along with cramps and nausea, along with bloody stools can be seen, and there will be high fever also if there is severe disease. Okay, so usually it will resolve within 5 days. The natural course is within 5 days. ORS plus hydration is the first line of choice, and if you have to start anything, then it is azithromycin, and alternative is ciprofloxacin. So avoid uncooked foods. Okay, and it is higher in third world countries. Okay, so this typically occurs in people who are coming from developed countries into developing countries because of the change in hygiene, because of the change in microbiome structure. That's why these changes occur. So rifaximin is used in case of non-invasive E. coli infection, that is we can use in enterotoxigenic. In giardiasis, similar thing only occurs, but here actually symptoms are prolonged. There will be long-term diarrhea along with the fat malabsorption and all will happen. Okay, and norovirus is known to occur in cruises, in ships in the sea. This norovirus diarrhea is known to occur. So some people consider this also as travelers diarrhea because it is most common among travelers. This giardiasis is more common in those people who go for hiking, who go for camping, no, and they drink this water through the streams. In them, giardiasis is more common. So don't give loperamide alone in diarrhea because it can worsen diarrhea. It has other side effects also. You should give along with the ORS, okay, and then you have to start empirical therapy also with azithromycin, or you should give ciprofloxacin. So don't ignore dehydration severity. You should see what stage of dehydration the patient is in the exam. Like if the answer is severe dehydration, then your first this one is to give IV fluids. Then assuming all won't need IV antibiotics, it is dependent on the severity of the disease. So most common causes enterotoxinic E. coli. Best empirical therapy is azithromycin. Risk factor is contaminated food. If watery diarrhea plus watery diarrhea along with travel history, then think of enterotoxigenic E. coli. If severe fever, avoid loperamide, and if persistent diarrhea is there, then test for giardiasis. So persistent diarrhea is more than 2 weeks of diarrhea. Okay. So every traveler's enemy is ET, EC. 3 to 7 days trip timing. ORS is the treatment of choice. Red flag signs of blood and fever, and azithromycin is given. Okay. So probiotics may shorten the duration. So probiotics has also a limited role in this, and high risk regions require stricter precautions. Yes. So moving on to next topic, ulcerative colitis. I think I have discussed this, so I'm not going into it again. I have discussed everything regarding ulcerative colitis, so please go through this. Next is viral hepatitis. Also, I have discussed everything. I'll just touch topics that I haven't touched upon. So important here is diagnosis. How will you diagnose? Okay, so HAV, hepatitis A is diagnosed with anti-HAV IgM. Okay, anti-HAV IgM is the drug of choice. Investigation of choice. And you will vaccinate the child also, not now, but after the acute episode, and then you will give supportive care. That's it. What is required in acute viral hepatitis A positive hepatitis. Now for hepatitis B, there will always be a window period. You should know this graph in and out. See, HBs AG will initially be positive after infection, and if immunity is strong, it will go on decreasing, and then it will be absent in the blood, and it will take around 6 months. Next, anti-HBC, that is anti-HB core antigen, that will start increasing slowly, that is IgM, and once HBs AG decreases, this anti-HBs increases. So this graph is very important. Questions will be asked on this. So there is a window period before which this anti-HBC IgM will be positive. So there is a window period of around 6 months. Okay. So during this time only HBs AG will be positive. For antibody response to develop, it will take around 6 months. This is known as the window period. Okay. So this should be important because initially you won't get anti-HBC IgM positive. Third, in case of hepatitis C, you will do 2 tests. That is, one is anti-HCV RNA test. Anti-HCV. That is, will find antibodies against HCV, and second is HCV RNA. And HCV RNA is a confirmation test because there you get number of copies, how much HCV RNA is there, and this is used as screening test. Hepatitis B, HBs AG dependent is HDV, that is hepatitis D, and we don't have any test for this. And HEV, we do anti-HEV IgM. Okay, there also we have supportive care. Now for hepatitis B, what is the drug that we give? We give tenofovir, we give lamivudine. Okay. And there are a few other drugs also, like interferon alpha we used to give earlier. So these 3 drugs, remember, nothing else is required. And here we have directly acting antivirals. Remember sofosbuvir, I'll write it here. Okay, sofosbuvir, and second is valpartacavir. These 2 drug combination is used for 3 months in case of hepatitis C. Okay, so I think I have explained everything. Yes, so I have explained everything. We'll move on to next question. That is next topic, that is vomiting and what are the causes, how to manage everything. Okay, so vomiting, it is basically forceful expulsion of gastric contents, and vomiting center is located near medulla. It is known as vomiting chemoreceptor trigger zone. Okay, chemoreceptor trigger zone, that is outside the blood-brain barrier. That you should remember. Okay, it is not inside, it is outside blood-brain barrier. So what are the causes of vomiting? It is not just GI causes. GI causes are just one part of it. GI causes like GI obstruction is there, or gastritis or pancreatitis. These are just one aspect. Second is central causes, like because of raised ICP, infections, migraine, okay, CNS triggers. So these also cause vomiting. And then we have drugs causing like opioids, which can cause vomiting. Now, what is the pathway for central causes? It is most commonly either direct insult to the CNS, or it is vestibular causes like motion sickness, Meniere's disease. Okay, so that vestibular system overactivity will cause vomiting. Then there are metabolic causes also, like for example, DKA, uremia, pregnancy. Then what is projectile vomiting? Projectile vomiting means patient will vomit and it won't just soil the clothes. It won't soil the clothes. It will be forcefully expelled out, and this won't be associated with nausea. It will be sudden, forceful projectile vomiting. Okay, so that is called projectile vomiting. What is bilious vomiting? Bilious means green color vomiting. It is seen in case of distal obstruction of distal GI obstruction. That is after the pylorus, that is after this pancreatic that gets after second part of duodenum, you will get bilious vomiting. It is seen mainly in intestinal obstruction. Non-bilious is in case of stomach pathology, maybe in case of gastritis or in case of other diseases like there is pyloric stenosis or in case of carcinoma of stomach or something like that, you will get non-bilious. Then we have okay. Once there is vomiting, you also have to assess dehydration signs. So what are the signs of dehydration? Tachycardia, dry mucosa, tears will be lost. In children, you will have increased skin pinch time duration. Okay, and there will be lethargy. So all those things will be there. Now, cyclical vomiting. What is cyclical vomiting? Cyclical vomiting means once every 2 weeks or once every 3 weeks, patient will have vomiting cycles. Okay, so continuous cycles. For 2 to 3 days, patient will be vomiting. After that, for 20 days, patient will be normal. And again, after for 2 to 3 days, he will be continuously vomiting. This is called cyclical vomiting. It occurs in migraine variants. Next important thing is cannabinoid. Okay, so this cannabinoid actually causes vomiting, hyperemesis. And in early pregnancy also, because of HCG peak, we'll get morning sickness. So now if it is a CNS cause of vomiting because of raised intracranial pressure, then there is no point in treating with antiemetics alone. Okay, and bilious vomiting should always tell you about intestinal obstruction, which is an emergency. And don't assume all projectile vomiting is because of pyloric stenosis. Even in CNS lesions also there will be projectile vomiting. So you should always assess for hydration in the question. You should also see for electrolyte imbalances and use if there is chemotherapy induced vomiting, we'll use ondansetron, or there are new drugs like granisetron which we'll use for chemotherapy induced vomiting. We also use cannabidiol. Okay, cannabidiol in refractory cases. Now, what are the let's answer some questions. Projectile vomiting seen in raised ICP, correct. Bilious vomiting, distal obstruction, that is intestinal obstruction, correct. Motion sickness, we give this is important. In motion sickness, there is no role of antiemetics like ondansetron and all, because ondansetron actually acts on doesn't act on vestibular system. It actually acts on serotonin receptors 5-HT3 and T4. Okay, so these receptors it acts on. Even domperidone acts on D2 and 5-HT4. So because of this, there is these receptors are not present in the vestibular system. So in vestibular system, H1, that is histamine 1 receptor, and muscarinic receptors are present. So you require something which can counteract that, and the drugs are anticholinergics. Okay, so drugs like promethazine, okay, then prochlorperazine, meclizine. Then you have hyoscyamin. Hyoscyamin is nothing but it is scopolamine. So all these are used in case of motion sickness. Okay. Next, if it is bilious, rule out obstruction. If positional vertigo is there, you should always think of BPPV. Okay. Next, morning vomiting, think of pregnancy or raised ICP. So I think I have explained everything. Yes. So there will be some trigger for vomiting, and there will be activation of this chemoreceptor trigger zone, which is known as CTZ, and it is outside the blood-brain barrier. Okay. That is an important parameter, that important fact that you should know. So next, last topic of GIT, that is Wilson's disease. So I think you know everything. You would have heard so many of these, but it's not that rampant in day-to-day life. Wilson's disease. I myself have seen some around 5 to 6 cases only so far, not more than that, of Wilson's disease. Yes, so Wilson's disease, I myself have seen only around 5 cases so far. So it's not that common, but in exams it is for some reason asked very frequently. So mutation is in this ATP7B gene, okay, 7B. If it is ATP7A gene, it causes Menkes-Kincaid disease, okay, Menkes disease. There is increased copper accumulation. So now impaired copper excretion and copper accumulation occurs in case of brain, in case of cornea, and in liver. So in liver it leads later to cirrhosis, okay, and cornea it leads to KF ring, and in brain it leads to encephalopathy. Okay, so it is autosomal recessive, presents in children or young adults. Copper accumulates in these 3 organs. Hence, it is also known as the cerebrohepatic lenticular disease. Okay, cerebrohepatic lenticular disease. So tremors occur, dystonia, dysarthria. These are the CNS involvement. Okay, so these are features of encephalopathy. Tremors, dystonia, dysarthria. Now in liver, we have hepatitis, cirrhosis, acute liver failure. I had once seen a case of acute on chronic liver failure, which means there was undergoing chronic liver failure, which was not diagnosed, but upon that there was acute liver failure, and they present as acute hepatitis only. So that also can occur in Wilson's disease. Now low ceruloplasmin levels is seen. Normal level is more than 20 mg per dl. What is ceruloplasmin? Ceruloplasmin is a carrier protein for copper. So low ceruloplasmin is seen less than 20 mg, okay, per dl. Elevated 24-hour urinary copper means in urine copper gets excreted, and imaging treatment, on imaging you will see basal ganglia there is hyper intensity. So that's why there is a problem with tremors, dystonia, dysarthria. These are the functions of basal ganglia. So what is the treatment? Penicillamine or trientine. Okay, we also use zinc therapy so that zinc will compete with copper in the digestive tract. Yes, see here, zinc decreases copper absorption. One important thing is this Wilson disease presents with hemolytic anemia also, because it causes something known as, whenever we talk about hemolytic anemia, there are two types of hemolytic anemia. We do Coombs test. If it is Coombs positive, then it is antibody associated. So it is body associated hemolytic anemia. Okay, we call it as autoimmune hemolytic anemia. Okay, so here there are some antibodies which causes breakdown of RBCs. There is one more type, that is Coombs negative, which means there are no antibodies, and one of the most important causes Wilson's disease. So in your exam, Wilson's disease presentation may not be just cirrhosis, KF ring. Don't expect it to be that easy. It can also present with hemolytic anemia, which is Coombs negative. Okay, KF rings are absent in purely hepatic cases. KF rings are seen in neuro cases. So if CNS involvement is there, then only you will see KF ring. Now only ceruloplasmin is of no use for us. We have to see ceruloplasmin along with that 24-hour urinary copper and other supporting diagnosis also. One more is psychiatric symptom. We actually had a patient who presented with psychiatric symptoms. She was evaluated at multiple centers, but they couldn't find out any cause, and then we had suspected she had actually Coombs negative hemolytic anemia. So psychiatric symptoms, she actually presented with depression. Okay, a 16-year-old girl who presented with depression, finally be diagnosed as Wilson's disease. And assuming adult onset excludes no, even in young adults also Wilson disease is possible. Okay, yes, so KF ring means Wilson, neuro Wilson we call it. Okay, CNS involvement. Low ceruloplasmin you have to suspect. If young plus liver plus neuro Wilson, if ceruloplasmin normal, still it is possible. And hemolysis liver failure, you should have high suspicion. So monitor kidney function test for penicillamine toxicity. These are like extension part of the question. For fulminant liver failure, you should do liver transplantation, and then you will have to screen the siblings also, because in them symptoms may not have appeared yet. So this is the end of GIT part. So initially first we had cardiology, which we finished in 1.5 hours. Then we had neuro, which we finished in 1.5 hours. Then we have GIT, which I think has taken around 1.5 hours only. So in 4.5 hours, we have completed almost half of portion. So I'm confident that in that rest of the things we can complete within 10 hours. So this will be the only source in entire among entire coaching sources that are available, which will finish medicine in less than 10 hours, so that you can read and revise medicine within one day itself. Okay, so next we'll go to endocrinology. After this, I have given space for PYQs. So solve PYQs, write PYQs, extra part, explanation part in this, so that this whole book, Medicine Endgame, will be one particular source for you for all information for regarding medicine. Thank you.